It's my great privilege to introduce Dr. Michael Smith. He's the Clinical Director at the Australian Commission on Safety and Quality in Healthcare. He's been a medical practitioner for 37 years. He's got a clinical background as a senior palliative care specialist in a tertiary hospital and a community-based practice in 3 states. In 2002, Dr. Smith was appointed the Director of Clinical Operations for Western Sydney, and in 2004 was subsequently appointed as a Director of Patient Safety and Clinical Quality for New South Wales Health. As I said before, the Commission are our strong partners, and we very much appreciate Michael coming across to give the Commission's perspective of implementing Standard 7.
Thanks, Lee, and good morning, everybody. How could you compete with that out there? Isn't this a wonderful spot? I love it. I actually trained in Adelaide, so it's really nice to be able to come back, and it's nice to see some familiar faces. The reason that we are here today, and Lee has, I think, undersold the impact that the National Blood Authority has had on the development of Standard 7, one of the National Safety and Quality Health Service standards. They really have been the driving force and the quality provider of the information which has led to that standard. Many of you, I know, I see a few familiar faces in the room, were actually part of the initial meetings that we had to try and work out what should the standard cover, how should it actually be developed, and so on. So it's really nice to see you here again. What I want to try to do today is to give you a feel for where and how the standard sits in the national approach now to the implementation of the National Safety and Quality Health Service standards and the whole question of implementation and where it sits. Most of the day, you're going to be thinking about practical, real-life things that are of use to you. One of my key messages to you is, one, do not underestimate the value of having a national standard. There is now a focus on blood and blood management in your health services like there has never been before. You have the focus and the attention of your administration, of your executive, of your boards, all sorts of people. So as you start to go forward and put forward ideas for change, as you put into place mechanisms to actually bring about changes in practice, you actually are providing them with a solution for something that they need to actually achieve. So there's a real game changer here. Instead of pushing against a closed door, you're now actually pushing against an open door. And I think you'll find that you'll get more and more support as you start to take your ideas forward. So that's my kind of key message out of today. So let's talk a little bit about the actual blood standard itself, and let's talk about the whole program of accreditation and quality standards. These are the areas that I'm going to deal with today, and we'll fly across them reasonably quickly. The first point here, I think, is that a lot of people get focused on the accreditation question. And you start to get, people get obsessed about, what happens with this with accreditation and, what are the particular questions that I'm going to have to answer and so on. How many of you, in fact, have already been through the accreditation program against the new standards? Can I get you to put your hands up? Yeah, that's about right, because across the country there's about, and we'll talk in a few minutes with some of the details, about a third of the hospitals across the country are actually going to be accredited this year. But the key message here is that the value of the health, safety, quality standards is in their implementation. It's a bit like when you do study, when you do a thesis. The value of the work is in the learning. It's in the year, or the 2 years, or the 3 years worth of work that you do. That's where the value of that work is. The exam at the end of the year is just a temporary phenomenon that really doesn't add anything to the value. What it does is that it actually verifies what it is that you've done. And this is how it is with the standards. The value is in your implementation of the standards. The accreditation is just the exam at the end of the year. That's all it is. Okay. Why and how these standards actually came about, and as you know, many of you, that there are 10 of these standards. They came about directly at the request of health ministers. Health ministers themselves wanted to see a unified set of standards for safe, high-quality care in all health services in Australia. And so this has been a 7-year program. It's taken an enormous amount of consultation, an enormous amount of iterative development to achieve the standards that we're at, and we've resulted in a set of standards that have been approved and accepted by all health ministers, and with their agreement, the requirement that every hospital in this country and every day procedure service in this country now must be accredited against these standards. They must implement these standards and prove it through an accreditation process from the beginning of January this year. So if you're not involved in it already, it's coming. And it'll come either this year or next year or the year after. And of course, a lot of this is about preparation, so that what will come about as far as the accreditation process will be, from your point of view, dead simple. Because frankly, if you do the sorts of things that the NBA is talking about and that you're already talking about, you will sail through any requirement for implementation of this standard. The scheme itself, the accreditation scheme itself, there are 4 kind of major players. I'm not going to go through this in huge detail, but it fits together like this. The health service organisations, you guys. The job, the responsibility of your health service organisation is 1, to implement the standards, 2, to pick an organisation that will verify that you're implementing the standards. Bottom right-hand corner there, you'll see the actual accrediting agencies themselves. There are now a whole range of them. Many of you, I think, would have been involved with ACHS in the past and had the ACHS accreditation. That market has now been expanded. There are about a dozen providers of service that your hospital can choose to actually have your accreditation process performed for you. Their job is to actually assess and to then provide the information and reporting back to your hospital, back to your regulator, who is your health department. And so the health departments in each of the states and territories are the regulators of the health system. You remember, the jurisdictions are the health system managers. They're the people who set the rules, the regulations. They're the people who determine what assistance your hospital or your health service will receive if in fact you're struggling with some parts of the standards. And then lastly, the Commission itself is really providing a national coordination role. We actually approve the accrediting agencies, so we give them the tick to say, yes, you're an agency that can be chosen and who can actually do this work, and we actually maintain and develop the standards as we go on. And a lot of what we do is actually providing some practical support to the health services in terms of what needs to be done in order to be able to implement these standards appropriately. So the standards themselves, there are 10 standards. Can I just ask how many of you have actually picked up and looked at, either the book or online, the information about the standards? Oh, you just do my heart so much good. I've got to tell you that it was quite fascinating when we were doing this similar kind of talk at the beginning of the year. A few hesitant hands went up. So it's really nice to see that it's actually something that's coming to the front of everybody's mind, and that's really important. Obviously, the one we're going to try and deal with today is around Standard 7, but as you can see, there's a whole range of other standards, and some of those will have particular implications for you. The ones that I want to draw your attention to in particular are Standards 1 and 2. Standard 1 is about governance. It's the governance, it's the involvement of safety and quality in the governance of your organisation. And Statement 2 is about consumer participation. It's about working with consumers. Now, the reason they're so important for you is that, in fact, all of the aspects of reporting and monitoring and having an organisational response to support you live within those standards. When we actually developed the standards to start off with, all of the different groups that were developing the standards wanted to keep saying, and the executive needs to see the results of our monitoring, and there has to be a system in place to do X, Y and Z in the organisation. And frankly, some of the early feedback said there's a lot of repetition in these standards. So what we did is we lifted all of that stuff out of each of the separate standards and put it together in one standard, which is Standard 1. So when you're implementing Standard 7, look at it, read it, think about it in terms of what goes on in Standard 1 and what goes on in Standard 2. Because Standard 2 is the place in which your organisation is now required and is committed to actually having the kind of patient engagement that you're trying to get in your whole question of consent. So again, it provides you with another lever that you can use in the organisation as you're trying to push some of these concepts forward. Excuse me. So the actions within the standards, not all of the standards, so each of the standard has a number of criteria, and each of those criteria has a number of actions. The core actions are those ones that are regarded as absolutely essential, minimum essential for safety and quality. There are also a number that are sitting in there which are really what we call developmental, and they are the areas that are really focus for further activity. They're the things that you should be aspiring toward. Now, within the blood standard, there are only 3 of the 23 actions that are actually developmental. But as you look at some of the other standards, you will see that there's some of them with larger proportions. The ones around patient engagement, for example, and consumer cooperation and involvement, there's a lot more developmental in there because really as organisations, it's not been part of the way we've necessarily worked. So we're giving people more time to be able to deal with those. There is a mechanism for determining non-applicability, just so that you're aware that that actually exists. From your point of view, clearly the blood standard is one that is going to be applicable to your service, otherwise you wouldn't be here. But let me give you an example. The dentists in Australia have actually put their hand up and said, we want to voluntarily make sure that we actually meet these standards. And so they've developed a voluntary process of assessing themselves against these standards. Now, one of the standards, which is probably not applicable to dentists, is pressure areas. If you get a pressure area sitting in a dentist's chair, clearly something is not right. So there's a mechanism whereby they can say, okay, we think that this is a standard which just doesn't apply to us under any circumstances, and there can be some prior agreement. On the other hand, there is a mechanism whereby a health service, a particular health service, can apply to its accreditation body and can say, we think a particular standard or the part of a particular standard may not necessarily be applicable to us, and there's a process whereby that can be discussed and considered and agreed to. So just so that you're aware that that actually is there. So that's the standards. Let's talk a little bit about the accreditation program. So as we said, the 2 key things from your point of view are making sure that down at that lower level you've actually got the connection and you're using the contract, the arrangement with the health service, between the health service and the accreditation body to get you what you want. One of the things that health services do have the capacity to do is to say not only will we be accredited against the safety and quality standards, we may well choose to be accredited against other kinds of standards as well. And that's a local decision which you may or may not then become involved in. The process itself leads to either a met or a not met judgment. There is a capacity, as you can see there, for what's called met with merit. I've got to tell you that of the health services that have applied thus far, there aren't any that have actually had the met with merit, and it's not surprising because the standard for that is pretty high. What it says is if you're going to be met with merit for a given standard, then all of the components have to be met. They have to be met across all areas of the health service, and the improvement has to be sustainable, and it has to be built into day-to-day activity, and it's evaluated. There's not too many at this stage of the game that can honestly put their hand on their heart and say, we're doing all of that. However, as time goes by, and clearly as more and more opportunity arises for change and improvement, we're going to start to see more and more people who are actually met with merit. One of the advantages and the reasons for putting that in play was simply to be able to give us an opportunity to point to a particular organisation that's really doing very well. Mostly so that people like yourselves can then go and find out exactly what it is that they're doing in order to be able to get that kind of categorisation. The other aspect of the work is that it was recognised that it's quite possible that as an accreditation process were to begin, something may arise that is clear patient risk. In other words, something is evident right at the very beginning that occurs, and there's a mechanism whereby that process can flag that up front. It can then be addressed while the accreditation process goes on. The idea is to try and step away from a situation where a problem is recognised, but it kind of has to wait for the accreditation process and the report and the whole series of things before there's any addressing of an immediate issue, and that's taken place. It's not possible now to actually accredit in the old way, where you give it to the quality manager, and you put together an enormous range of paperwork, which is so heavy that no accreditor would ever dare ask a question, and you spend 3 months doing papers, and then you put them away, and you store them nicely for 3 years, and then you bring them out again in 3 years' time. The whole new approach in the quality standard world now is one of implementation and risk management. So the drive that'll happen in your hospital will be the thing that you've been trying to do for a long time, which is measure your risk, work out the steps that you're going to take to reduce that risk, do something about it, and then monitor it. That is required across all of the standards and across the whole of the hospital. So again, it provides a vehicle for you to put in place the sort of thinking that you've got in mind with regard to patient blood management. So risk management, absolutely key. The health service has to demonstrate that it's assessed the risk and that it's taking approaches to it. The other advantage of this is it means that you can tailor what activities you decide you want to focus on based on the risk that you've identified in your place. It's not a question of everybody has to actually follow exactly the same process in every hospital across the country. It's about saying, where is your biggest risk? You will already have some things that work really well for you. You don't have a risk in a given area. Don't focus on that. Focus on the areas where there is the biggest risk to patients and the biggest risk of patient harm, and do something about those areas. That'll be what's expected of your health service, but it'll also be what the accrediting people are looking for, that you're actually focusing your attention on the things that actually are going to reduce patient harm the most. The old paper war. I talked about the 3 or 4 kilos and 10 folders worth of papers. The whole idea of this new process is the evidence that you need to provide for accreditation will come from the material that you use every day. If you're doing a risk assessment, you're putting in place a change, you're monitoring that change, and you're providing those reports up to your transfusion committee, your quality committee, your board, it's all of that which is the evidence. It's not that you have to produce voluminous new amounts of work. This just falls out of the work that you're already doing. So this year, because this was a first year, because it was a change, there have been some special arrangements put in place for health services during 2013. But of course, we're almost 3/4 of the way through 2013 now. Those included, first of all, for those hospitals that were involved in a mid-cycle assessment, and you remember your accreditation, you have a full, for most of you, you would actually have a full assessment, and then you'd have halfway through the cycle a mid-cycle assessment. Now what we've said is, okay, it's 1 and 2, plus 3, which is the healthcare acquired infection standard, plus any special recommendations which may have come from your previous assessment. But when you actually then go to a full assessment, clearly it's against all 10. Extra time to address the not met actions. In the past, if there has been a recommendation that you do something, you've been given 90 days to actually address that. That's been extended out to 120 days now. And we are finding that for a number of hospitals that have already gone through the accreditation process, they are needing that 120 days, and they're using that to be able to put in place the changes that allow them to actually meet the standard. And clearly for this year, we actually did, after some further discussion, put a few more items into the developmental basket so that, in fact, again, particularly around Standard 2, there was the capacity to be able to make progress toward the better engagement with consumers, but not necessarily to make it a black and white, you're not doing enough. Okay, so where are we at the present time? Well, there is just over 1,300 services that need to be accredited in this 3-year cycle. And this year we've got around about a third of them, 420. And interestingly, there was an approach made that we recognised there were going to be some hospitals, some health services that would actually need to have a little bit of more time. And so we arranged with their accrediting bodies to be able to give them an extension on their previous accreditation. We thought it would be the small private hospitals that might struggle with that. In fact, the privates have picked this up and they've just flown with it. No problem at all. The services that have said, oh, please, can we have some more time? The big publics. And that's been very interesting. So this year, some of you will have delayed your accreditation process a bit. It's not going to happen next year. If you're up for accreditation next year, then you need to be ready. You need to be thinking now about having the things in place that you're going to be talking about today so that you're ready to rock and roll when it all turns up next year or the year after. Okay, this gives you a sense just of what's going on. You can see that the third row from the top gives you a sense of what's happened with South Australia at the moment. It's really just a bit of an overview of kind of where things are going. Most have actually undergone a mid-cycle, and to date, none of the health services have in fact had difficulty in, none of them have failed. But what's happened is that there's a fair number of them that are still using their 120 days to bring about change. And the interesting feedback we're getting from those that have already undertaken the process is these standards are making a difference. Are they easy? No. Do we have to do something different? Yes. Are they impossible? Absolutely not. This is stuff that we've been wanting to do for a while. This has given us an incentive. It's given a drive in the hospital for us to be able to do it. So that's really encouraging because I guess that really suggests that we've got the balance about right. So again, this is something that people are going to be looking to you for solutions. They're going to be your hospital's going to be looking to you to say, how do we meet these requirements? What's the way in which we do it? And that'll give you a lot more opportunity perhaps than you've had in the past. This question of notification of significant risk, I just draw your attention to Service 2 there. There was one organisation where as the accrediting agency came in, it was clear because the organisation had lost some key staff that they had a really significant problem in their blood governance arrangements. That was notified immediately to the hospital, really before the accreditation process started, and also to the regulator. And action was taken which actually fixed that real patient safety risk problem very quickly. And that organisation actually then, as they went through their process, then passed their standard without any trouble at all because of the remediation that had been put in place. On the other hand, I'll give you one example of a small privately owned day procedure service in New South Wales that had decided to expand its surgical capacity, and that was really good. So they were then performing surgery in the upstairs of a Sydney 2-up, 2-down terrace building without even the capacity to be able to get a stretcher up and down the stairs in that building. That was notified to them, and then when the owners of that whole program actually were notified of that, they immediately stopped the surgery until their major renovations had occurred. So, it gives you a sense of the sorts of things that do go on and how using a standard like this can actually help make a difference. Okay, so the blood standard itself, I'd really want to acknowledge, I think at this point, both Philippa Kirkpatrick and Joe Cameron from the MBA, because a lot of these slides are actually their work, but I guess we've already covered off a lot of this. Lee has already mentioned the reasons why we want to do it. I just draw to your attention the key objective of the standard, and that is that managers implement systems to ensure that, in fact, that the use of blood is safe, appropriate, effective and efficient, and that the clinical workforce use the blood and blood product safety systems. So in other words, we use the systems that are in place. We've talked about the criteria. The intention here is that the actions in Standard 7 form a transfusion quality improvement program. And it's that quality improvement program which is continuous and ongoing and building all the time is the key thing that we hope to see in terms of actually using this. What about resources? Well, the NBA, as Lee has already said, have a huge number of practical resources for you to use in your special area. If you want more information and you need resources about the standards and the accreditation process, then our website and our organisation are more than happy to be providing that. There are some specific practical workbooks for the implementation of standards in hospitals and day procedure centres. Can I ask who here comes from a small or rural hospital? Is anybody? Okay, you guys get your own special workbook. It's on the web now. The idea is it's really hard when you're in a small or a rural hospital to be able to look at all these standards and think, crikey, Moses, how the heck do we do all this? Well, in fact, what we've done is we've really taken it and put it together in a way, and hopefully, and the feedback we're getting thus far is that it seems to be working, that for you guys there's then some practical, real advice on how to be able to do this in what is a much smaller organisation, and for times when you don't necessarily have staff that are used to using blood all of the time, so it has particular risks associated with it, obviously. Each of the standards has the delightfully named SQHs. The SQHs are practical supports for each of the standards, and Standard 7 has got one of those. And in particular, the thing I would draw your attention to is this phone number. There is a 1-800 number which provides advice, and also online, practical advice to you if you have questions about implementation. We've had, our website hits, there's probably about 200,000 hits on the accreditation and standards pages on our website over the last 9 months, which gives you a sense of the focus and interest that's coming from the health system around this. Lots of other people are paying attention to this at a time when you want them to pay attention to it as well, and that's really good. And there's been well over 1,000 calls into the advice centre. That's resulted in frequently asked questions, etc., and so on that are there. Feel free to use it. You can ask about anything as specific as you want or anything as broad and general as you want, and you should be able to get an answer from our advice centre. There is a website, and you can go there, and that's where you actually find the information and the frequently asked questions. In terms of what's coming up next, yes, there are going to be reviews of the standards as we go along. They are not going to significantly change before 2017. So you can be comfortable that the standard you're working with at the moment is the standard you'll need to work with for a little while. There may be a little bit of change around some of the core developmental stuff, but it really isn't until 2017 before we expect to see any significant change. And the change will be because the feedback from people like yourselves will say, here is an improvement that now needs to be made. We've moved on since you first did this. This is what we now need to do next. And so that will lead to a change in the standard. So any particular questions that you have, please feel free to go to the website. There's a lot of really useful information in there. So final messages. Number one, the world is on your side. There's a focus now on safety and quality in the organisations which did not exist before to the same extent. It's now built into governance, and you can take advantage of that. Secondly, the biggest assets are sitting in the room. The experience that you have and the experience that your colleagues interstate have in these areas is particularly important. It's really, really good. And thirdly, don't waste the opportunity that accreditation will provide you, because it is a little bit of a stick, a lever that allows you to build on the things that you're trying to do. Happy to take some questions. Oh. Not too many people get applauded for accreditation, I've got to tell you.
Question.
There you go. Excellent.
I've got a question for you, Mike.
Yeah. Okay.
In terms of specifically the standard 7 on blood and blood products, what's the sort of feedback you've been getting in terms of its achievability, where it could be improved,
Look,
problem areas?
As you saw, it's relatively early days, and most of the services that have actually been accredited thus far have tended to be smaller private services, so they have a different set of difficulties and arrangements. But from both those private facilities, but also from the fewer but larger public services that have come back, the feedback's pretty solid, it's pretty good. And I think the reason for that is because so many people because the world that you guys inhabit is a relatively concentrated one, it's a relatively small one. And so many of you and your colleagues in the state were actually involved in the development of the standard in the first place. So it really didn't come as much of a surprise to very many people. And I think the feedback we are getting has been that question of, it's nice to see that the hospital is very keen on doing this as well, and it's not just about money. It's actually about patient safety, because that's one of the biggest hooks. I can see a nod there. Yeah. Because the money argument is always important, but it's personally, I think it's overrated, because what happens is that if you're a chief executive and you sit there and everybody that comes to you with a really good idea says, I can save you money. But the bottom line reality is it doesn't save me money. What it actually does is that, in fact, my money stays the same. My budget stays the same. It might mean that I can use some of that money for another purpose, or it might mean that I can use it more efficiently. But the thing that is actually occupying my mind as a chief executive and as an executive of a hospital now, much more than it ever used to, is about the safety of my patients. Because if you think about all the things that have happened around the world in terms of patient safety over the last 10 or 15 years, what's the thing that actually concentrates the mind? Scandal. You don't want things to go wrong. You don't want things to go wrong badly. But importantly, you worry all the time about two things when you're a chief executive. One, can I pay my payroll? And two, am I safe? They always worry about, am I safe? Is my service safe? Because it's actually very hard to tell. What you're offering is an opportunity to say, you do this, we'll be safer.
Any other questions? Michael, on behalf of everyone here, thank you very much for your time and coming down from Sydney to give us an overview of the standards. As I said, they're hinge pin, and that's what today's about, and that's been a great introduction. Please join me in thanking Michael.